Okay, welcome back to our next lecture covering soft tissue mobilization, different clinical indications and techniques for these new strokes that we're going to be learning. Some of the objectives we're going to look at include just discussing categories of physical agents. In this particular lecture, we're looking at soft tissue mobilization and its effect in tissue injury and repair. And we're going to kind of skip past some of these other ones, but going to be looking at contraindications, things along those lines as well. So what is soft tissue mobilization? Well, this is any technique that involves manual hands-on pressure, stretching of soft tissues, rhythmic movements to help improve tissue function. And our main goal here is to enhance circulation, improve flexibility and range of motion, and of course, reducing pain and muscle tension, which can also help promote healing. So I would start this slide if I were you here. So put a little star by this one. These are going to be the techniques that we're going to be learning in our lab setting. So the first one that we were looking at is called Effleurage. The description of this is these nice gentle gliding strokes, typically starting distal and then moving towards the heart. We're just trying to improve lymphatic flow, improve venous return. So we always want to start distal and move more proximally there. The purpose is to improve circulation and also to warm up the tissue to maybe some deeper strokes that we're going to get into here in a second, and to relax our patients. They want to feel like they're in a therapeutic environment. We want to make sure that they're ready for the more challenging activities that they're going to be performing later, as well as kind of relaxing them and getting them prepared for our deeper soft tissue techniques. So we can use circular or linear strokes when we're looking at Effleurage. And then we're going to move into Petrissage. So something that you also, let's go back to Effleurage for a second. We're always going to start our treatments with Effleurage, and then we're also going to end our treatments with Effleurage. So we're going to warm up the tissue, maybe move into something like a deeper kneading, rolling stroke, which would be Petrissage. And then we're going to finish with that Effleurage again. So always make sure that you start and end with Effleurage. When you look at Petrissage, this is more of a lifting, kneading, rolling of the soft tissues. This is typically what you would think of whenever you use those massage chairs, tables, any of those home devices that you really enjoy using. Most of those different things that you're using are going to be using more of this kind of Petrissage technique. The purpose of using something like Petrissage is to reduce adhesion formation, so maybe under like a surgical incision. We can also decrease muscle tightness if somebody has something like a trigger point release or there's myofascial tightness there, and it helps to improve elasticity. So we can use these deeper strokes to increase that range of motion, whereas before with Effleurage, we're just looking at improving circulation. Okay, so more examples here: kneading, ringing, skin rolling. Those would all be good examples. The next one we get to is Tapotement, aka percussion. You're going to be using percussion in semester 5 whenever you start to look at pulmonary drainage techniques. So this is one that you will see again later on, and you'll have another skill competency that covers percussion. The description of this one is rhythmic tapping or striking using hands or fingers. We're going to use basically a cupped hand to percuss the areas of the lobes of the lungs that we're trying to drain. So we'll look at that too here in a second. We can also use a hacking with like the knife edge of our hand to help stimulate deep muscle activity, things like that. The purpose for Tapotement is to stimulate circulation. It kind of activates that nervous system, so trying to activate or facilitate muscle action, and energizes a little bit too as well, so it's getting them ready for those different types of activities that we're going to use following our soft tissue. So hacking, cupping, vibration are all going to be some things that we look at in semester 5 for sure. And the last one here is cross-friction mobilization or cross-friction massage. This is where we apply deep pressure to applied perpendicular to the muscle fibers or tendons. we need to know obviously the alignment of those different structures so that we can go across them. This is really good at helping to break up adhesions, scar tissue formation. It promotes collagen remodeling. So after somebody's been immobilized for a long period of time, we have collagen synthesis, we have tissue healing. But if there are no stressors applied to that new collagen, it's going to be really immature and it's going to be weak and it's not going to be able to sustain much stress. So the first stress that we may introduce would be something like cross-friction mobilization. So we can use a thumb or a fingertip stroke. We're going to cover those in lab to really see what those look like. But again, start this slide, make sure you know the description and the purpose of these techniques. So here's an example on the left-hand side here. We have somebody using a cross-friction massage, maybe to that MCL area. So the MCL runs this way. We're going to use our fingertip strokes to go across the fibers, just like that. So really beneficial on tendons, ligaments, things like that. And over on the right-hand side would be an example of that skin wringing or skin rolling, some people call it. So again, trying to lift the tissue up, break adhesions, possibly improving range of motion. Another example of Petrissage here on this first image on the left-hand side. So again, that's a little bit deeper stroke than we would see with Effleurage. Effleurage would be this middle picture here. So again, starting distally, moving up and out, trying to promote some of that venous or lymphatic return. And on this side here, this last little image on the right-hand side, we see something like a Theragun. Many of our patients have these at home, so you can show them the best use of those different devices. But this would be something more like Tapotement or percussion. We're using, these high velocity movements here to send sound waves through the tissue, stimulate, decrease soreness, those kind of things. That'll look a little bit different when we go over the ribs and we're trying to use percussion for pulmonary drainage. But you can always teach your patients how to use those at home. I would maybe not use them so much in a clinical setting because, again, your patient can utilize that at home under the right supervision, or at least have some instruction on how to use those at home. Something that we need to talk about, part of the purpose that we use soft tissue techniques is because of this physical stress theory. So we know that our tissues and our bodies, they really rely on stress to adapt and to strengthen and to become stronger and more resilient to injury. So again, maybe soft tissue mobilization is going to be the first type of stressor that we introduce to our patients before they get into strengthening, before they get into aggressive stretching techniques. So we need to use these appropriately and ensure that we are getting the correct response. So this physical stress theory, again, helps tissues adapt to stress by encouraging regeneration and resilience. Okay, part of the same reason that we go to the gym, right? We lift heavy weights, we create micro damage in our muscles and our tendons and things like that, but our body adapts to that and it becomes stronger over time. That being said, you can't just go into a gym after you've never lifted weights or you've taken years off and go back to lifting the same heavy weights that you were lifting previously. So we need to really promote a good progression of our soft tissue work as well as our therapeutic exercise and activities. Again, this physical stress theory can help increase fibroblastic activity by stimulating collagen production, and that's obviously going to help improve tissue healing and that resiliency towards re-injury. The other thing that something like a cross-friction massage would do would be to improve the tissue organization and fiber alignment. So when our tissues are put on stretch or we're asking them to perform high-level activities, strengthening, things like that, our tissues are going to stretch and our fibers are going to be nice and parallel to each other. That's going to make sure that we get enough stretch. Like let's say this is our tendon here, okay? That's going to make sure that we get enough lengthening, flexibility, and strength. Whenever we have an injury and we're immobilized, we may get these randomly oriented collagen fibers like this. So this may be some immature collagen formation in the tendon, but as we start to use these soft tissue techniques, as we start to use therapeutic exercise, we're starting to induce stress to the tissues. We can start to realign those fibers so that they become more resilient to stretch, more resilient to any type of tension that's put through it. So this is our end goal, right? We want to make sure those fibers are nice and aligned so that they can adapt to that stress and they can really take that stress on without the risk of re-injury. Something that our soft tissue also helps to do is enhance blood perfusion. So it helps to increase oxygen and nutrient delivery for faster recovery. So just thinking about our metabolic rate and how we can really improve our metabolic rate. Obviously, if we're getting blood to the area, we're improving vasodilation, we're doing all those things, our metabolic rate should go up, right? And what comes along with increased blood to the area, oxygen and nutrients. Those are two things that you absolutely need for tissue recovery. Something else that's pretty interesting too is there's been a few studies that have shown these mesenchymal stem cell stimulation as a result of soft tissue mobilization. And these really help to encourage regenerative processes in injured tissues. So if you don't know what these mesenchymal stem cells are, you can maybe do a quick search, but essentially these form in the bone marrow, and there's really like an unrecognized tissue, so it has the ability to adapt and become something very different. So it may just start out in the bone marrow as this mesenchymal cell, and then as we adapt and as we introduce stressors to areas like at the site of tissue injury, it can then adapt and become a collagen cell. So it has the ability to adapt based on those stressors, based on the stimulation that we give to those certain tissues. Another thing that soft tissue can really help improve is this neural activity. So if somebody has a lot of pain, we can reduce neural activity, typically by gating pain or breaking what we call a pain spasm pain cycle. So if we can get those muscles to relax with Effleurage, with some of those deeper Petrissage techniques, this is going to help us reduce pain for our patients. And obviously, this decreased muscle tension. So we talked about that physical stress theory. Here's just a little table that kind of shows the impacts on our tissues with physical stress levels. So this is kind of the golden area right here. So we have maintenance and we have increased tolerance. Those are where we want to stay within, okay? You can see that below maintenance, we see decreased tolerance levels, aka atrophy of muscle fibers. And then we have the death, which is our ability, or it's our loss of adaptation of those certain cells. So for our patients that come out of surgery and they've been immobilized for long periods of time, they're probably going to be at this decreased tolerance level. They're going to have some atrophy. If we start to use things like soft tissue techniques, we can maybe get back to that maintenance level and then eventually get back to this increased tolerance level where we're seeing hypertrophy and increased tissue tolerance to injuries. However, we can also go in the opposite direction. We can go above that increased tolerance and we can start to see those same things. So if we overtrain in the gym or we overtrain our patients, there's always a risk of injury, right? If you don't take any days off during your lifting schedule, or you're a marathon runner and you don't take those rest days, the likelihood of injury is pretty high there. And after that, we still see death or this loss of adaptation. So again, we really want to stay in this area here, increased tolerance and or maintenance level. Lots of different reasons that we would use our soft tissue techniques for. First one being musculoskeletal conditions, any tendinopathies or impingements. We're going to learn what these really are next semester, so we'll maybe store those in the back of your brain, and then we'll talk about what a tendinopathy is, what an impingement is. If there are ligament sprains, we can also use these soft tissue techniques, joint mobilizations, things like that. If there's any pain dysfunctions, we can utilize soft tissue techniques to decrease myofascial pain or trigger points, and any type of other secondary soft tissue dysfunction. And then we have our structural issues, scar tissue, entrapment syndromes, postural syndromes. We can use those different techniques, especially something like cross-friction for scar tissue remodeling and decreasing the likelihood that scar tissue is going to form just by applying those stressors early on. We haven't really talked too much about entrapment syndromes, but one that I just think of off the top of my head would be something like carpal tunnel syndrome, or CTS. A lot of folks will go, automatically distal to the carpal tunnel where that median nerve becomes entrapped, but that may not change their symptoms if we just address just that one area. So you may have to look up towards the pronator teres muscle. Okay, I'll just write PT there, pronator teres, because the median nerve actually travels through one of the heads of that pronator teres muscle. So if we have decreased range of motion and we have tightness in that muscle, we can also entrap that median nerve more proximally near the elbow, and we can still see some of those same signs and symptoms that are typical with carpal tunnel syndrome. So that's just one of the entrapment syndromes that we're going to mention again in our next semester. And then we can always help improve postural syndromes. So a common one is upper cross syndrome, where we see the forward shoulders and the rounding of those shoulders with really lengthened rhomboids, middle traps. So their scapula is going to be basically stuck in this pronated, I'm sorry, not pronated, but protracted position. There may be downward rotation of the scapula. So we need to address maybe the anterior side of the shoulder, lengthen the pec major, lengthen the pec minor, get some horizontal abduction going. So we can use our soft tissue techniques to really loosen up those tight muscles, and then we'd follow it with strengthening, with rows and things like that. We can also use mainly just effleurage for these reasons here. So if we have decreased blood circulation, maybe somebody has venous insufficiency, decreased venous return, we can use that really nice light stroke to improve fluid motion, improve that venous return more proximally. And we can also use that with post-surgery individuals as well. Lymphedema is a really good one for this effleurage stroke. So these gentle strokes really help to promote lymphatic drainage. We haven't necessarily gone over lymph massage, which you'll see that in semester 5. It looks a little bit different than what you might expect, but we'll get to that point in just a few semesters. We can use effleurage to help manage muscle spasms or anxiety, mainly because this calms the nervous system and it decreases stress. And of course, just remember that we are always going to begin and end our treatments with effleurage. So moving on to Petrissage and indications for this. If we have muscle and fascial tightness, we can use Petrissage to help release any of those knots that you might find, like typical in the upper trap region or in the quadriceps. We can also help to improve pore circulation with this Petrissage technique. This just encourages venous return and improves blood flow. So starting more distally and moving more proximally, again, kind of like what we saw with effleurage. We can use it if there is decreased flexibility of muscle tissue. So we've looked at, I showed you our little instrument that we use for instrument-assisted soft tissue mobilization. We can use some of those deep kind of Petrissage-like techniques to help improve flexibility, decrease muscle stiffness. We're really just trying to prepare our patients for functional movement here. So once we get the range of motion that we want, we need to work into that range of motion with our activities. And something that I like to do too with these Petrissage techniques is basically an assessment of muscle play. So if you grab that muscle belly and you move it side to side and you compare it to the uninvolved side, you'll notice if there are any restrictions or adhesions that are limiting movement of that muscle or that tendon. So a good example would be you can just grab your biceps brachii and you can move it side to side. And if you've had an injury to that biceps brachii, you may notice that you get less movement of that muscle belly or that muscle play. And that would be a good indication to use something like Petrissage. And the next one here is Tapotement. So we are going to really focus in semester 5 on these pulmonary conditions. So if your patient has pneumonia, has cystic fibrosis, or COPD, the likelihood that they have kind of mucus buildup in their airways is pretty high. So what we want to do is use that cupped hand to percuss right over the lobe that has the restriction, and that's going to help loosen the mucus for easier expectoration of that mucus. So we're going to teach a productive cough technique. Ha or a k sound is something that we're going to learn on top of this percussion stroke. And like I said earlier, you can also use this stroke to help with deep tissue stimulation. So it stimulates those deeper muscle layers, and this is usually used for athletes to help increase muscle activation or recovery. So here's an example of that nice cupped hand technique that I was just talking about. So this is the technique that we would use, and we would percuss over the segment of the lobe that is restricted. And this will look really familiar to you when you get into semester 5. You'll probably have to know at least a few of these positions and the different sections or those segments of the lobes, okay? So we're not going to be focusing on that in this semester, but depending on where that restriction is, you're going to need to position your patient appropriately. And then on these little areas here, like these little blue ones up top, that's where you're going to perform your percussion at, okay? So we'll get more detailed with that, but we're kind of just introducing Tapotement for those later skills that you're going to have to learn. And the last one here is indications for cross-friction mobilization. So we're going to use this when we see decreased tissue strength. So we're going to use this technique to help promote tissue remodeling and restore that resiliency of the tendon. If we have these kind of randomly oriented collagen fibers, again, this is going to help realign those disorganized fibers to really restore functional mobility and improve that tissue resistance. If we have decreased range of motion, cross-friction is another good technique that you can use to help improve flexibility by breaking down those adhesions that form in the muscle belly themselves or near that tendon or the ligament. And again, we've just talked about adhesion formations. We really want to make sure to target scar tissue and improve the mobility of those tissues to reduce stiffness and improve range of motion for our patients. Here are some of the contraindications to soft tissue mobilization. So acute injuries or inflammation, open wounds or skin infections, fractures or severe bone conditions. So osteogenesis imperfecta, severe osteoarthritis would be some of the things that you'd have to look at. If there's an active DVT, then we're not going to use any of these techniques. We saw that most of these techniques are going to help improve circulation and improve venous return, all those things. Well, that's not necessarily a good thing with a DVT formation. We're trying to not make this embolize and go further into the lungs or something like that. Another thing that we're going to avoid is soft tissue over active cancer areas. There are some other different forms of soft tissue mobilization, and maybe just write a little asterisk by that, not because it's important, but because some people in the clinic use kinesiotaping and they bill manual therapy for it to either inhibit muscle action, facilitate muscle action, or to improve lymphatic drainage. I don't know if that's the best place to bill it for, is in our manual therapy section here, but it's something that I see often. So you may see that when you go out to your clinical rotations. We do have instrument-assisted soft tissue mobilization. I really recommend that you take a CEU course before you start laying into people with some of these different tools. So make sure that, once you're graduated and you know that soft tissue mobilization is going to be a good part of your therapy sessions, continue your education. Make sure that you get certified in one of those courses that relate to IASTM. Last one here, a lot of people think this is a very popular, it is a very popular technique that we see in clinic, cupping. There's not a lot of research to back cupping, but there are some indications that I would use it for, like to improve soft tissue flexibility, typically near scar tissue. So for a patient with total knee arthroplasty, they have this really long incision down the center of their knee. Let's just say this is their knee. And I would place a cup right over this area once it's healed, fully healed, of course, and I'd apply some lotion. And then I would move this cup up and down as kind of a dynamic cupping to help lift the skin and break any of those adhesion formations that might be happening just superficial, just underneath that incision. But static cupping, the reasons that you would see that helps improve circulation, things like that. There's a lot of studies that don't really justify the use of cupping. So just be, aware of that when you start your practice. Here's some, instrument-assisted tools that you can use. The Graston technique is one of the most popular, and they have their own tool set. So I have the one tool. Graston has all of these different tools meant for different body parts. So there is some benefit to, spending the money and getting this certification. You get a whole tool set essentially instead of just one. You can contour areas of the body very easily using some of those. And here is an example of cupping on this side here. So this would be kind of similar to what I would use cupping for. It's hard to say if they're doing this this mobile cupping technique where they're moving it back and forward over the incision, but this is one thing that I would use cupping for. Again, right along this incision to kind of break up any scar tissue or adhesion formation just underneath the skin. Okay, so now I want to finish up with some joint mobilizations and just different techniques. Well, not different techniques, but different terms that you may hear and indications for why you'd use joint mobilizations. So just remember the APTA stance on joint mobilizations for the PTA. They say that it requires this constant reevaluation and assessment of the joint in question. Well, PTAs cannot reevaluate. Therefore, the APTA states that PTAs really shouldn't be performing joint mobilizations. Now, it is up to each individual state practice act to determine whether or not PTAs are allowed to do these techniques in clinic. But here in the state of New Mexico, most of our clinics are going to just expect PTAs to be able to perform joint mobilizations to assist with increasing range of motion and decreasing pain. But it is very important to know our professional organization stance on that. So when you're doing joint mobilizations, make sure that you are very cautious and make sure that you have some type of competency that you've passed with your supervising PT that shows that you have the skills to do these things. Definitely going to stay away from grade 5s. No go on those ones. No high thrust manipulations, okay? So just be cautious. We're going to review some of these different indications for why you'd use joint mobilizations. So just remember that when we are using joint mobilizations, we can use these to help modulate pain, or we can use them to treat joint impairments that limit range of motion. So we'll talk about that. Why do we use grade 1? Why do we use grade 2, 3, and 4? That'll be on our next slide or here very shortly. This is the one that's off limits no matter what. Even if you've had training, you don't want to do these high thrust manipulations as a PTA. So we're going to stay away from these ones. There are some other techniques like mobilization with movement. So this is a concurrent application of sustained accessory mobilization applied by the therapist and an active physiological movement to the end range by the patient. So we're mobilizing the joint, maybe a grade 3 or grade 4, and the patient is actively moving into the position that we are trying to increase their range in. So we'll see some of these, we'll practice these, I'll show you some different techniques in lab. Another really popular manual therapy technique are these muscle energy techniques, or METs. This is when we have our patient perform a gentle isometric contraction, which is used to help relax the muscles. We're trying to really correct positional alignment, things like that. So it's really common to see that in the hips if somebody has anterior or posterior pelvic tilt. And we utilize these different forms of inhibition, so autogenic or reciprocal inhibition. Okay, so we're typically looking at stressing or at least stimulating the GTOs, those Golgi tendon organs. Remember that these guys are really stimulated by tension and the amount of tension that the muscle is providing. At a certain point, with enough tension, they're going to relax. They're going to release the tension that they're being asked to provide. That's a protective mechanism that you may experience when you're lifting weights in the gym, things like that. But these two terms are going to be really important when we start looking at our stretching and our range of motion, flexibility, in semester 4. So go back and look at those ones. Whenever we're performing joint mobilizations, it's important to also know the arthrokinematics and the osteokinematics. So remember that the roll is always going to be in the direction of the angular movement or the direction of the bone. Okay, so if we look at this picture here, B, we can see that the starting position of the femur was here, and it's moving backwards just like that. Okay, or that's what we're going to say is happening right here. So as the femur goes posterior, the joint would slide anterior. Let's go to this one because this is what's really happening here. So this is the direction of the femur. It's rolling posterior, and the joint itself, the joint surface, is sliding in an anterior direction. So you have to know the convex on concave rule to understand the roll and the slide. So the roll, again, is always going to happen in the direction of the bone, and the slide is going to happen in the direction that the joint surface is moving, or that translatory movement. So this, in image A here, you could kind of picture, right, if this is the motion that the joint starts in and the bone moves backwards, well, now this portion of the joint is way up here. So it's sliding anterior, okay, as the bone rolls posterior. So if you're still having a difficult time with the arthrokinematics rule, I linked a video here that you can click on. There's been some studies that suggest that the direction of the slide or the mobilization isn't as important as just performing the slide itself. But whenever we're learning these arthrokinematics, we really want to reinforce that the slide, the direction of the mobilization is in the slide to improve that range. Okay, so now let's look at these different grades of joint mobilizations. So we have our grade 1 through grade 4. Those are the only ones we're going to really talk about. So grade 1 is a small amplitude technique performed at the beginning of the range. Remember that 1 and 2s are meant for pain modulation. Okay. Grade 2 is a large amplitude performed within the range but not reaching the limit of tissue resistance. When we get to grade 3s and grade 4s, these ones are the ones that are meant to improve range of motion. So our grade 3 is also a large amplitude technique, but it's performed up to the limit of available motion and are stressed into the tissue resistance. So we're actually stretching the joint capsule now. Grade 4 is a small amplitude performed at the limit of available motion and stressed into that tissue resistance again. So grade 3s and 4s, we're stretching that joint capsule. With grade 1 and 2, we are not getting to that limit. Okay, so I'm going to skip past this because this is what we just talked about. And here's another example here that kind of shows you the different oscillations and the tissue resistance. So here's our point of limitation here. Here's our anatomical limit. We're never going to get to that point. Even with the grade 5s that we can't perform, we never get to that anatomical limit. But our grade 1, again, small oscillation, you can see that represented here. It's very far away from the point of limitation or tissue resistance. Grade 2 is a large oscillation. It's still not getting up to that point of limitation, but it's deeper than a grade 1 is. Grade 3 is also a large oscillation, and we're getting to that point of tissue resistance or that point of limitation. And a grade 4, at the limit of range of motion, but a small oscillation. Okay, so that's pretty much all I have for our soft tissue mobilization lecture. I hope you found this helpful. If you have any questions, feel free to reach out to me directly, and thank you so much for watching.